I think this is one of the questions that usually we discuss in many conferences and also in this conference. And particularly in this conference, there will be two important presentations. One has just been done, and the other one is about to be discussed about the complexity, after chemo IO. When I was young, I started operated on patients after normal chemotherapy, and we found it more difficult than with respect to upfront surgery because of the adhesion, because of the loss of the planes between the vessels and the parenchyma and the tumor. And we have found that after chemoimmunotherapy, surgery is even more difficult, probably because of the inflammation of the fibrosis induced by immunotherapy, which is the effect that we want, of course, for these patients. But on the other hand, we have developed improvements in the surgical technique. We have more technology. We have more devices also to take care of the intraoperative complications. And in the series that was presented this morning, the vast majority of patients operated after chemoimmunotherapy could be performed via minimally invasive therapy, which is good. Because the patients after thoracoscopy or after minimally invasive techniques are more ready to come back to normal life, and the postoperative period is easier, and these patients can tolerate much better adjuvant treatment as compared to the open accesses. So I think we are working. We have the tools. And I am very confident that we can operate it also on these patients safely and with minimally invasive techniques.
So nowadays we have enough data to support new adjuvant chemo IO and adjuvant IO in the early stage of resectable non-small cell lung cancer. When we look at all data across this trial, maybe stage 3 or stage 2 can get much more benefit from this therapy. The PCR rate, pass CR rate is around 20 to 25%. Not bad. It's seldom seen with adjuvant new adjuvant chemotherapy and target therapy. So I do think the stage 3 or stage 2B get more benefit from perioperative new adjuvant perioperative chemo IO therapy. The safety profile of this therapy is acceptable. So majority of patients experience grade 1 or grade 2 adverse events. Majority of these events is manageable with common practice, So I support new adjuvant plus adjuvant the chemo IO in early stage of lung. We should do it. That's an important question we didn't answer so far. According to clinical trials, the duration of adjuvant chemo is about 1 year, right? So, but we are not sure what's standard proper duration of immunotherapy, especially for those with past CR patients. 1 year immunotherapy is maybe too long. Some study is investigate 6 months of the adjuvant immunotherapy for past CR patients. Anyway, we need data. We need clinical trial to determine proper or optimal duration of IO in these populations.
I completely agree. I think that the next step will be to select the patients that would benefit or would not benefit from adjuvant therapy. And so, I mean, the focus of our research in the next years, we all know that immunotherapy is effective, so there's no word about that. But we have to select the best patients in order to make the great benefit. For example, if after surgery you have a pathologic complete response, for example, shall these patients receive adjuvant chemotherapy or not? Because in theory, they are cured. So there is no residual disease. Of course, we need some biomarkers like the circulating DNA, for example, in order to see if there is some teeny tumor cells in the blood. And in that case, of course, a systemic therapy in an adjuvant setting might be effective. But I think that the focus of the next research will be just to select the population to which offer or do not offer adjuvant chemotherapy after chemo, IO, and surgery. This is my...
I totally agree. We need a biomarker to select right patient for perioperative chemo IO. As to biomarker, so far, we do not have solid biomarkers. We know that PD-L1 expression may be associated with better efficacy of perioperative the chemo IO. In near future, we should look at circulating DNA, circulating tumor cells. But so far, we have not established testing platform. What's the standard method to test the ctDNA and circulating tumor cells? We need study to confirm predictive effect of these biomarkers. We need to study, we need thoracic surgeon, we need medical oncology, we need translation scientists to work together to find the best biomarker for our data practice.
Again, we come back to the previous discussion. So once again, the de-escalation depends on the biomarkers. Again, the selection of these patients. So if we know that this treatment is not effective, okay, we can de-escalate. But so far, we simply, to my knowledge, we do not know. And so, again, we need studies. We need data in order to make assumptions, to make evidence. But if there is any ongoing trials, I think that Professor Zhou can explain much.
That's a great question. So far, we do not have much data to answer the question. But we do know we need novel compound, novel agent to improve efficacy. In China, we have bispecifics to combine with chemo in perioperative setting. So far, the safety is quite good, but we need the better efficacy, right? So we also have a study investigating on ADC based the therapy, the CHOP2 data ADC combined with IO. In the phase 2 trial, we need waiting for the results of this study. There are several novel compounds is also studied in neoadjuvant setting. So far, I will say that the combination of therapy is acceptable, but we need the efficacy data, especially we need phase 3 trial to confirm the efficacy and the safety profile. Anyway, there are so many novel compounds. We have bispecifics, we have bispecific ADC, we have ADC and insectual. Maybe the combination of this compound could further improve efficacy. And therapy, we should balance efficacy and safety. If the treatment is quite effective, but not too toxic, is not acceptable in our daily practice. We also need to consider economical toxicity, right? That's very important. Nowadays, to cost expensive, the therapy is not accessible to many patients. We need to consider the balance, the efficacy, safety profile, and economy toxicity. That's my idea.
And probably different countries have different policies. For example, I don't know, in Italy, for example, all these compounds, all these drugs are reimbursed by the state. And so the state, of course, has a considerable economic cost, economic burden. Okay, the patient don't pay for the drug. This is what happened in Italy, but of course, any country has some different healthcare policy. But this is something that has to be taken into account. And I really liked the concept that Professor Zhou raises, that was the economic toxicity. If there is a toxicity, of course, this is a cost. It's a cost for the state to take care of the complications, to take care of the toxicity, not only the cost of the compound or the cost of the drug, but also the cost of curing and treating the adverse effect. I really like this concept, and of course we need to make a global discussion on that, and this is something that has to be taken into account.
Yeah, I totally agree. When we look at efficacy, we should counter the PET CR rate. If we also need to consider long-term survival, not only median overall survival. We should consider how many patients could be cured with a lower the therapy. Nowadays the PCR rate with chemo IO is about 20 to 25%. Can we increase the rate up to 40 to 50%? That's acceptable, right? We need to look at this efficacy data, not only the partial response, MPR, etc., but cure rate is very important.
What the patients want are to be cured and to live long, not to have a complete pathologic response. Of course, maybe they are correlated, but we don't know.
That's a great question. What we treat our patients, yes, improves the quality of life, not wasn't quality of life. If the new therapy could not improve quality of life, or is not acceptable in our daily practice, quality of life is very important. Yes, patient report outcome. We should pay more attention to that.
Yes, I cannot agree more. I had a look at the posters, for example, and 2 or 3 posters addressed this issue, very important issue, the quality of life. We have measures, we have metrics to measure this, the quality of life. And again, this is part of what we call the patient-centered medicine. So to put the patient at the center of our cure. And if we would like to put the patient at the center of our treatment process, this means also to take into account the quality of life. In my opinion, it is completely worthless to cure patients, but to destroy the patients. I mean, to reduce the patients with a very poor quality of life, psychological, functional, and we need to provide a balance in that. And so for this reason, I think that your question is very pertinent. Yes.
Thank you very much for giving us an opportunity to present our data. In this study, we got very good 5 years survival rate, 27.8%, not bad. 5 years PFS rate is 18.2%. Excellent results. This data suggests that about 1/4 of patients could get clinically control for 5 years. About 18% patient could be disease control more than 5 years. Not bad data, So therapy is not only improve median overall survival, but couple of months. Couple of months for lung cancer patient is nothing. What is very important, right? If we nowadays, we should counter how many patients could survive longer. 3 years survival rate, 4 years survival rate, and a 5 years survival rate. I do think long-term survival rate, such as 5 years survival rate, could be the primary endpoint or key second endpoint in the future clinical study. We need to consider the therapy with good long-term survival. That's my thought,
Yes, just a brief comment, but of course, the study was for advanced disease, if I understood correctly. But I think that just thinking of a 5-year survival in advanced disease, this is something absolutely unbelievable. So just a few years ago, it was absolutely absurd to talk about 5-year survival in advanced disease. And so, of course, Professor Zhou, his group, and his team should be congratulated, because this is a fantastic achievement. This is something that, of course, needs to be implemented and needs to be verified, but this is really an impressive result. I think that we are living in a really exciting period for lung cancer and for thoracic malignancies as well. So I would like to extend, the concept. This conference was designed for 3 thoracic cancers. So lung cancer, thymic tumors, and pleural mesothelioma. And in each of these, I think that thoracic surgery can play a great role. So can you imagine now with the use of integrated treatment like chemo, IO, plus adjuvant, perioperative. So really, this has really changed the scenario of the role of surgery, even if in more, let's say, more advanced disease. We are now talking about salvage surgery. That means surgery after definitive chemo, radio, and immunotherapy. So again, surgery continues to have a role in the treatment of lung cancer. As I said at the beginning of this interview, we now have much more technology, much more tools, much more devices in order to provide these patients a very safe surgery with a short postoperative period in order for this patient to recover quickly, in order to get access to, for example, adjuvant immunotherapy, adjuvant chemotherapy, and this is a major step forward for thoracic surgery. So, and I was very glad that I saw a lot of Chinese posters here. I know many Chinese colleagues, and you are really in the front line for thoracic surgery. So you're doing a fantastic job and I can see the results of my thoracic surgical colleagues in many conferences in the US, in the Europe, and again. So we are a big family. So we are all together. And I'm very glad, despite some people, it's important to have this big community to interact. We have all the tools to communicate. Okay, we have Zoom calls. Sometimes you are very early in the morning. Sometimes you are in the middle of the night. Sometimes we are in the middle of the night. But it is fun. It is fun. Every time I communicate with my Chinese colleagues, so I'm very happy, and the same for the US colleagues, and so on. So this is for lung cancer. For pleural mesothelioma, again, we are now discussing the role of surgery, which was put into discussion with the new MARS trial, the MARS 2 trial. But again, this morning we discussed that surgery can still have a role also in pleural mesothelioma. And finally, for thymic surgery, for thymic tumors, surgery has an indisputable role across all the stages. But once again, the key to this success is the multidisciplinarity, is to talk together, talk to the medical oncologist, radiation oncologist, pathologist, pulmonologist, and that's it. This is the key. If there is no communication between us, between the continents, between the countries, well, we don't go anywhere.
Surgery is in the center of the treatment of thoracic cancer, right? The lung cancer, thymic tumor, and mesothelioma. We need surgery. We are a team. As a team, we should work together. We should communicate together, right? In that way, we can improve the cure rate of our patient. We can change the history of cancer. We should work together, right? Thank you very much.